good evening, and good night, friends from all over the world. As we are writing history together, today we have two wonderful guests from our host from Portugal, Dr. Raquel Zita, and
Hello.
also our speaker from Germany, Mr. Frank Zastrow. He's not new to many of us. Welcome and thank you for joining us today.
Yeah.
So I would like to start with introducing Dr. Zita, our host today, and give you guys a little bit of background. Dr. Zita is very well known in many different groups and is very active. She works restlessly on a daily basis to bring information to our colleagues. On her personal group, Follow the Red, and if you notice, she is uh, frequently in red, as she is today, and sometimes with red shoes.
Okay.
It's part of the wonderful brand that she has built around her teachings, where we also need some fun. And you can always follow the Red with over 25,000 members at some point, and very readily to find. Dr. Zita is very active. She's a medical dental doctor, as well as a PhD, an oral surgeon. Dr. Raquel Zita Gomes received her PhD in implantology from the Faculty of Dental Medicine of the University of Oporto, where she also received her dental medical doctor and master's degree. Her thesis investigated experimental study of a new biomembrane, MES, for guided bone regeneration. Dr. Gomes also completed postgraduate work in implantology at Brennemark Institute in Gothenburg and maxillofacial surgery ward at Västerås Hospital in Sweden, and a specialization course in implantology at the University of Oporto, if that's not enough, folks. A life dedicated to education, training, learning, sharing. We're very proud to have Dr. Gomes, who was also one of the originals from the 2018 Global Summit that was conducted in Los Angeles, and also is a regent of the board for the top 100 doctors, as well as now the top 1 million doctors. So thank you for joining us. I'll switch over to Dr. Gomes to introduce our speaker. Thank you, Dr. Zastrow, as well, for participating.
Thank you, Kianor. Thank you so much. Thanks for inviting me to be a host of Frank, because I was very happy. I know him quite a long time, and I really appreciate his work. And thank you also for your effort of bringing all these speakers together, do the top 100 doctors in the world, and create this platform that is sharing the knowledge from speakers from 72 countries. To the goal is to reach 1 million dentists. Now we reach already 400,000 in the last days. We started in 15 of April, and we will finish in 30 of May. So if you want to see the webinar, they are all for free. You can go to the gis.com, the site, or go to the Global Summit page in Facebook, and you can see this live streaming and also the other complementary webinars that you can see it whenever you want. So now I'm going to present our speaker. Most of you know him because he's well known in the world, not only presentially, but online too. He's from Germany, everyone knows that, Dr. Frank Zastrow. And I'm going to talk a little bit about his credentials. So Dr. Frank Zastrow has a master's degree in oral surgery, is an international speaker and founder of the international Facebook group Real Bone Builders, that you should go and see because it's really an amazing group and has thousands of followers also. It's a platform with more than 10,000 of doctors worldwide who focus on biological bone augmentation, the BBA concept, and the reconstruction of severe intraoral bone defects with purely autologous bone and tissues. So it's a very specific concept that only utilizes autologous tissue or bone. After he finished in 2004 the dental school in the University of Heidelberg, Germany, he became a research associate at the Oral Surgery and Maxillofacial Surgery Center in the University of Heidelberg. Until 2012, he was senior physician at Professor Fuad Curie in the clinic Scholz Schellenstein in Germany. And since 2012, he is owner of a private clinic, Dr. Frank Zastrow and colleagues in Wilhelmshaven, Germany. I hope I said the names correctly.
All perfect.
So, as you know, Dr. Curie is one of the not inventors, but in the principal names that are linked to the Curie technique. And Frank was working with them, with their team for many years, and now he has also his legacy. So I will pass the word to Frank. I hope everyone enjoy his webinar. And please, if you have questions, post it on the comments, okay? We will going to select, if you have too many, we'll select the best ones. If there are not too many, we will give all the questions to Frank. So at the end, I will reappear and do the questions to Frank, and we are going to do some moderation of the topic. So if you are interested in knowing something more, not only about the lecture or about Dr. Frank Zastrow, please put in the comments and we will find a way to introduce him a little bit better. So back to you, Frank, and good luck.
So, thanks so much for your introducing words. It's really so great to have a wonderful host like you. It's really my pleasure. And of course, it's also a big honor to be here on this GIS Summit, to be one of the speakers. And I also want to welcome all of you to this webinar, and I'm just changing now to the full screen. And the topic today is biological bone augmentation. What are the basics and where are the limits? And some of you know already my platform, like on Facebook, the Real Bone Builders community, or also my Instagram account, Dr. Frank Zastrow. We are working since more than 12 years now, or 11 years, with pure autogenous bone, nothing else, only vital bone. And you see also many cases, meanwhile, not from only me, but from many participants and former students. And in the past, usually when I started a lecture like this or a webinar, usually I showed some studies. Usually you're choosing then those studies which are supporting your position, but all of us, we are not naive. So we know that for each study we are citing there at least 5 or 10 other studies that say exactly the opposite of this one study. So that's why I want to start with maybe a little bit provocative, but the sentence of a good friend of mine who said this recently on a big stage. So please don't take it word for word. It's more about the overall meaning. So he said, don't believe all studies, don't believe the guys on stage, don't believe me. Instead, only trust your eyes, and I think you can call it your gut feeling, because only your own results, what you see, determine your way. And I think there is some truth inside. We should first think, we should stay critical, not believe everything we read. Instead, think if this makes what you see sense from a biological point of view. Fail. I think we all failed in the past. This is how we grow. So you, me, and this is actually the way to learn. And also my father, he was a dentist. He also failed in what he was doing, and he also grew in this. And he was also placing implants 40 years ago, one of the first. And you could even call him one of the pioneers in implantology. Like all those colleagues, those times were pioneers, because I think it was very brave. You didn't know the long-term results. Will it really work? And I'm asking you now, nowadays, is it so much easier? I think it's still challenging. I think the reason for that is...
Dr. Zastrow, sorry, your presentation is not up. Your presentation is not working properly. Can you please open it back up again? It says it failed. Are you on a,
or not?
Are you on a is this your slide that says fail?
Yes.
Okay, it stopped for a second. We should be okay now.
Okay, perfect. So I think it's still quite challenging nowadays, implantology, because we have a surplus on information. So we have the World Wide Web, we have Google. So I think it's hard to find the right informations, and this is actually the challenging part. And nobody has actually the time to go all through this information. And the more I really appreciate that you are sharing now your precious time with me and with this webinar. So, and what we also should not forget is that behind many of this information, of course, there are also interests. So when you're doing a study, for example, and those of you who are doing it, you know that you're going to maybe the head of university and you're asking, and the first question will be, okay, who is sponsoring it? Which is normal. This is how life goes. But usually when you have sponsors from a company, they want to have good results. So I'm here from Germany. We have some nice car companies, for example, Porsche. Imagine they are doing a study, okay? And at the end, the result is that BMW is better. Do you think they would promote it or present it somewhere? Probably not. So just stay critical. And actually, the more I feel privileged to talk about a topic and a material which has no sponsor, because it's the patient's own bone what we are talking now in the next 1 hour about. So I don't want to bore you with my CV. Raquel said already some words to it. So I'm right now here in Heidelberg. I was senior physician at Professor Fuad Khoury. And we are also doing courses. So when you're more interested in seeing our courses online or offline, just go on bba-academy.com and you will see all what we are doing for education online and offline. Usually I'm traveling right now with the pandemic situation, of course not. So this is the reason why we have this wonderful chance now to meet here in the online world. And this is my Instagram account. Just 2 weeks ago, this was still 16,000 something. Now we are hitting almost the 18,000. So please feel invited to join our Instagram account. It's quite interesting because most of the cases are also not mine anymore, only also from many colleagues who have really wonderful results with this concept, working with pure autogenous bone. And this was in China. Also there, the concept is not that well known yet because, of course, there is no money to earn. That's the reason. So there is, actually not like with other materials where are companies behind. I think this is the reason why it's not that well known yet, like it should be, in my opinion. So you see here my team, my clinic. So I'm very grateful to them that I have the chance to work with them. Also, when I'm abroad, they are there and helping our patients. So we are doing general dentistry there. We are not doing only surgery. We are doing also crown bridges, functional disorders, endodontics. We have our own laboratory with milling machines, master technicians. So we do the whole package. But we also, you see it on the left lower corner, also doing our courses with live operations and everything. So maybe one day I can welcome you here in my city, Heidelberg. It would be my pleasure. And
Dr. Zastrow, sorry to intervene. The slides aren't shown in the live feed. Could you please log out of it and log back in? You don't see the video on you.
So log in what?
Let me just see if we can get it back into the stream. Your slideshow. Let's see if it will come back onto the stream. Hang on 1 second. My apologies. I just got some messages that your presentation wasn't playing.
Okay. Now try again.
Hang on 1 second. No, it's still not playing. Are you in a full screen mode?
Yeah, but I can go back like this now. Do you see my presentation or not?
No, it's not. Yeah, if you don't play it full screen, that might work. Let's go ahead and try.
But it's not possible. It's videos, and I have to play them in full screen.
I see. Hang on 1 second. Let me see. Right now in the live link. 1 second, please. Let's see if it comes back up. No, we do not see. We do not see it here on the screen.
You want me to go out from this shared screen and try to share it again?
That would be wonderful. That might solve the problem.
So I remove this one now and I try it once more now. It comes back. Do you see it now?
Let me go ahead and bring you in. Hang on 1 second. Let's show it in the stream. Go ahead and hide here. Okay, let's see if it will come up in the live stream accordingly. Hang on 1 second. All right, doctor, hang on 1 second. Yeah, it will. It shows it now, but you may wish to jump the videos if it creates that problem again. But it's starting up again. If you like to start fresh from the beginning of your slide, feel free.
So you see now the video from Heidelberg. So this is the old bridge from the 13th century. Actually, I see it from here right now from my office. This is the old castle from the 17th century, and the old town with the longest pedestrian zone of Europe. So maybe one day, if you want to come here, it's also good for shopping. Maybe not right now, but hopefully very soon again. So old bridge, old castle, old town, everything old. Let me ask you a question: is old good or is old bad? So maybe strange question. So at least when you're going to a congress, what you're reading is a new innovative technique, and usually not old technique. So I don't want to disappoint you now, but the next 45 hours we are talking actually about a very old technique and even older material, because we're talking about millions of year old technique and material. We are talking about evolution. So the vital bone is actually very, very old. And in my opinion, this is even more powerful than all new materials. So, but I was working differently in the past. So allow me to share actually just one case because I was trained in GBR and I moved then actually to working with autogenous bone. And I was planning differently. Those times when I had cases like this, I was planning here to remove the teeth, and usually when you have a socket, you fill it with something, right? So we come later to this point if it's really necessary. And you have other areas where you have still enough bone, like here. You can place implants immediately, but the challenging areas are those where you have a thin crest usually, or maybe a vertical defect. So imagine you just have removed here the teeth, or you had a bridge here maybe. These are the challenging cases. And when you're an expert, or if you want to become an expert, you have to get along with those areas, because those are also the cases which you get referred, not the easy ones where you have enough bone, where you can just easily place the implants, because the referring doctors, they will do it themselves. They refer to you as a specialist those challenging cases. At least in my hands, I know some colleagues have wonderful results. In my hands, because in my opinion, it was only osteoconductive. It didn't work so well. So the first failures occurred, and I didn't do statistics those times, but in very thin crests, I had maybe a failure rate of 30%, which means on the other side, we have 70% success. So I'm asking you, is this good now, or is it maybe not so good? So I think it depends how you see it. I think only when you see it's not good enough for you, then you can grow, then you can keep growing. So take it as a challenge if you don't have the success rates you want. So I changed my concept those times. I was actually too scared, because it's not just a case or an implant. Actually, it's a human being behind, it's a person behind, and each failure is actually one failure too much. So I changed my concept in that way, that especially in those challenging areas, I used more minimal invasive procedures, smaller, thinner diameter. I avoided overall augmentative procedures. Or what else can you do when you're not able maybe to augment bone in the posterior area in a predictable way? Just remove the teeth in the frontal area and do an all-on-4. This was a little bit like a joke. Don't get me wrong. I think all-on-4 is a wonderful concept, but sometimes I see cases also on social media where I think this is maybe not so well indicated, because maybe the frontal teeth are still okay from a periodontal point of view. And I'm not sure if these colleagues would do this also to their best friend or to their mother. So you should always treat each patient like it would be a family member or good friend. So first time when I heard about working with bone, I was actually not believing it. So because I was thinking, okay, when you're working with bone, this resorbs. So the favorite sentence, actually, my favorite sentence, it's melting like snow in the sun. Probably also heard this. And I asked my colleagues, and they said, oh, it's also quite dangerous because you can cut the nerve. And besides that, it's very painful, and overall, patients, they don't want it. They don't like when you're taking blocks. So with this information, actually, I was stuck. I was insecure to go that way. But then I had two situations which made me think again. And one was, yeah, like I said before, a very good friend of family. My father, who was also dentist, placed here the implants. And you see the consequences now we had after 20, 30 years here, perimplantitis, so vertical defect. And my father, who was dentist, also told her, no problem, because I was already a surgeon. He said to her, my son, he can fix this easily, okay? But those times, at least, GBR didn't work so well in my hands. In fact, this is what I felt. I felt actually scared. What did I tell her then? So I told her, yeah, we have to stabilize the situation first. We have to do some prophylaxis cleaning. But in fact, I was just too scared to be confronted with a vertical defect in this challenging situation. And there was another case which also made me think, again, like an eye-opener. It was a young student, so it was not her. This is from stock photo now, but she looked similar. And I was, those times, it was 2007, yeah, working in another private clinic where we did only GBR. And yeah, it was like a factory. Actually, we placed more than 100 implants per month, only GBR. The concept was actually to get primary stability whenever you can, and the exposed threads just covered with some bone substitutes, then membrane and closure. And yeah, and sometimes it works, in many cases not. And also in this case, it actually, yeah, was a horrible result. All the substitutes came out, and young, beautiful woman, but a very big recession. So I didn't know how it went on, because she moved then to Berlin for studying there. But in fact, to be honest, I blamed my boss for doing this to her. I didn't say something, but I was just thinking, how could he do this to this young woman? But do you think now this is fair to blame somebody if you have no better alternative? Because I moved then to Berlin for studying there. But in fact, to be honest, I blamed my boss for hearing myself now. Okay, good. I just had an echo. Okay, wonderful. So I think it's not fair if you're blaming others, because yeah, actually only when you have something better. And this, I didn't have those times. And then it was first time that I saw Professor Curry, my former mentor now, and I saw first time the concept of biological bone augmentation, working with pure autogenous bone. And I was so fascinated from this concept that actually during this congress, I asked him during the coffee break if I can work in his clinic. And the most amazing thing was when I was staying there 4 years almost, that we started in the most compromised situations you can imagine, with a lot of scar tissue, very poor regeneration potential, and still we were able to bring almost 100% of those cases to a success. So on the left side, Professor Curry, on the right side, Dr. Schmidt. I'm very, very grateful to both of them that I learned from them. And yeah, so this was me, those times, still with hairs, and yeah, probably too much stress, and was a wonderful time. And yeah, so we are coming now, before we are coming to the cases, I want to share a consensus paper with you. This is from the Federal Association of Implantological Active Dentists in Europe. And the goal was, you see, for many key opinion leaders, to give a classification of defects for regular cases with bone augmentation. And you might know former classifications like from Cawood and Howell, or from Seibert, maybe even more famous. And very interesting here was to see that in more than 50% of the cases, we have a mixed form. That means not only horizontal, but also vertical defect, which is important to keep in mind when it comes to the regeneration of these defects. Before we are coming to the table, I want to show you here how we differ between the defects. We differ between lateral, vertical, and combined defect. We differ a bit between the sizes, so small, medium, and large. And now, and this makes it special, first time that we are differing between inside and outside the contour defects. What do I mean with that? You see on the left side and inside the contour defect, that means we have a lot of bone walls, which makes it easier to regenerate. On the right side, we have actually an outside the contour defect. That means here we have to create first a new contour before we can place the implants. At least this is the way we recommend for getting predictable results. And this webinar is about the challenging defects like the right side. And when you see this table first time, it might be a little bit confusing, but we will go through it and then it will be very clear. So we see here first the group associated with the patient's own bone, like the split, the chips, block and hip bone. Then the group of GBR, first pure, then with bone chips, and then distraction sandwich, which is not the topic of this today's webinar. Then you see here the different defects, like a horizontal, vertical, and combined, a special form, the sinus. And below that, you see small, medium, large defects. And on the left side, you see here now the inside the contour defects. And on the right side, you see the outside the contour defects. And you see already, when you look at bone block, the indication, and for example, also GBR, you go on the right side, the indication. You see on the left side, you have much more crosses. On the right side, you have less crosses because it's not indicated for many areas because it's only osteoconductive. So it's hard probably to go vertical. But before I want to go now to blocks, I want to share you an old case from mine. Those times I was still working with the GBR. And you see here the coverage with bone substitutes. When I use my membranes, I usually tag them with tags or pins to get really good primary stability. And yeah, after maybe 5 or 6 months, what you have then is a situation like this. You see here, it all looks good, but I opened it. I was curious. I wanted to see how it looks like, okay? And this is what you find. And actually, I'm asking you now, is this bone? I think in many cases, we have no bone. And this is, of course, a risk when you have saliva, you have bacteria, and you always have bacteria, that this goes inside because it has not this immune defense, in my opinion, like real bone around the shoulder area. So only autogenous bone has, as gold standard, these 3 mechanisms like osteoinduction, initiation of new bone regeneration, osteogenesis, that means building new vessels. And of course, it also works like a framework or scaffold. We call this osteoconduction. I know you have seen this already 1,000 times. Now you see it 1,001 times, but I think it's important to remember that this is really the difference to all other materials. And we have here also vital osteoblasts. And the challenge now is to keep it alive, because in many minds or many, you think when we are talking about bone, about these results like here on the right side, white bone. This was a patient treated in my clinic after the bone augmentation was done in another clinic where they are working with full cortical blocks. This is the problem. It was integrated cranially, but you see it's totally white, and this is not what we want to have, because here we are starting a resorption. So osteoclasts, macrophages are activated and we will get some resorption. This is not what we want to have. Just for fun, I call it ivory augmentation. So white bone, dead bone, not what we want to have. Now comes what Professor Curry invented, so the so-called split bone technique, or also biological bone augmentation, meaning we are particulating the block into small pieces, and now we have faster access from the blood vessels. That's the secret. We have faster access. That means we can keep the bone alive, or at least a part of it, and we have a better nutrition. And for those of you who think, okay, this might be not so stable, yeah, that's right. So one part is split into thin bone plates. You see it here. They are placed on distance. And this is filled now with, actually the particles. And then we have red bone afterwards, okay? Red, vital bone. And this is not resolving, not more than normal bone. Because I'm asking you now, imagine you would take a biopsy here, okay? What would you find in this biopsy? I think we all agree that we would find bone. And now I'm asking you, is there like a quality B bone or C bone? Or is there only one bone? We all learned that when we were students, that bone is the only tissue in the human body which comes to its original state after healing. And we should remember that. It's not like soft tissue where you have, for example, a scar tissue. No, bone becomes the same bone like before. And I really know what I'm talking about. My brother, he's orthopedics doctor. So, you know, in Germany, we have here Autobahn, highway, unlimited speed. Those guys who are surviving it, they are coming to his clinic. And yeah, so some of them have 20, 30 fractures, and they're all healing. And after a half a year, nothing will remind you that there was a fracture, okay? Bone is really healing, and same here. Of course, you have to place implants here, so to give functional loading into that bone, but then the bone is same stable like the bone was before. This is maybe the most important take-home message. So this bone does resolve, okay? This is the same bone like before, because what else should it be? And you have to place here the implants. It's red vital bone, and this is what we want to have. So 2 cases I brought with me because it's just a small webinar, and we just have yeah, another 40 minutes left maybe. And I was starting actually here with a simple sinus floor elevation. So we work only in sinus. That's the only indication where we are working also with bone substitutes. You see it here. We also did yeah, in the frontal area some lateral bone augmentation. And you see here after a couple of months, we have the re-entry. We are placing now our implants. And now look the difference. What you see in the sinus, okay, and what you see in the frontal area. In the frontal area, you see also the screws. Also on the X-ray, you see the area. And this is vital bone. This is what we want to have. And bone substitutes, many times, if you really look carefully, you know, sometimes you can just remove it like sand on the beach. And still, it's used in 99% of the cases worldwide. Only maybe in 1% is used blocks, which is a pity because I think it's a really nice alternative. And yeah, unfortunately, this case, the patient came to us back. You see the horizontal bone loss on the X-ray and has a strange feeling in that area. So we actually measured the pockets and we found, okay, something is going on there. So we explored it then, and what we find was actually, yeah, a fistula. We didn't see it before. It was chronicle, but it was a big infection inside. And we knew, okay, there is really something serious going on. So we opened it totally up. And what you see here now, we cannot keep the implants. We have to remove them. And not only the implants we removed, we also removed actually the bone substitutes, because look very carefully, they look like, yeah, the day before. So they were totally not integrated. What could have been the reason? Sometimes the reason is that some saliva bacteria come inside, and because there is no immune defense in these particles, okay, substitutes, the infection can go through it like through sand. So with autogenous bone, we don't have this because we have here this immune defense. And now we have actually, we are confronted with not an inside the contour defect anymore. Remember when we had the sinus inside, a lot of bone walls? No. Now we are confronted, actually, you see it here in the mirror, with an outside the contour defect. We have actually a very thin crest. And if we would use now the same principles again now with bone substitutes, probably we would get also the same result again. So you have to up level now, upgrade for the next level. You need a more powerful technique and a more powerful material, which is yeah, only osteoinductive, osteogenetic. And you see here how we are taking the block from the right mandible. So this is the micro saw, so from Dentsply, but you don't need this. So anyway, they have just delivery problems. So you can also do this with piezo surgery, okay? So piezo surgery is wonderful. You can do this. It takes maybe a little bit longer, but it's very wonderful. And you don't have to be scared from it, really. No need to be scared. Maybe you remember the first slide, one of the first slides I showed you when I said, yeah, so actually it's so people told me in the past that it's dangerous, but when you're staying with the safe protocol, and later I will give you the safe protocol. Here, this is 40 pages we made. I give it to you later when you're interested. 40 pages, step by step, how to do the bone harvesting. And in fact, there's really no reason to be scared of, because many of you, or most of you probably, you're also removing, for example, wisdom teeth impacted, right? So in fact, actually, it's a little bit paradox, and it's also a little bit funny. There is no other area in the intraorally where we are more familiar with than with the retromolar area. So sometimes we are totally destroying with a big burr all the bone on the right side, but when it comes to collecting a small block, we are suddenly scared. It's actually a little bit paradox, so don't be scared of it. Also, recent study, 4,000 bone harvesting, showed not one permanent anesthesia when you stay with the rules. and they are all here inside. I will give it to you later. The second point was the question, is it painful? It's no painful, because if it would be, then also your implants, the patient would have pain afterwards. There is no sensitivity in the bone. That's why it's not painful. If you put something into the bone, like an implant, or if you take some bone out, no pain. So if somebody tells to you this, unfortunately, you have to say it's a lie. The last point I really have to, I want to talk just a little bit about it, was this limiting beliefs that the patients don't like blocks. Probably many of you think your patients don't want blocks, right? So let me answer you this way. So imagine you have maybe a disease and you need to go, for example, to a heart surgeon, okay, who is doing heart surgery. And you know he's really the best one. He's the expert, okay, or she. And he or she is telling you then, okay, we have maybe three options, maybe option one, A, B, and C, okay, and he or she recommends you option Z, okay. Would you ever not follow his or her advice? Probably not. You would follow the advice, because what you want is a result. You want maybe to survive, okay. The way there, the method, actually you don't care. And it's the same with us. When the patient comes to us, the patient cannot decide what way he or she chooses, because he or she didn't study dental medicine. So they trust in you. They should trust. So it's up to you what way you choose. And when the patient comes to me, I say maybe there are three ways. Also, you can do this with cow bone and maybe with some dead human body bone, or we're doing it usually with vital bone. We're taking it from here. It regrows, important to say, and usually we have nice results. The patient has usually no question to this. The only question might be, okay, really from cow bone or from bones from dead human body. So because the patient sees that I trust 100% in this result, and you will do the same. Actually, you will have the same then. But what is the biggest enemy? The biggest enemy is actually you, or better, let's say your routine, because you're used to something. You're used maybe to GBR, which is okay. So when you have 100% safe result, that's fine. Stay with it. If not, this is maybe an option, and you see then maybe first the nice results, but you have to step out of your comfort zone. You have to do this little step, and afterwards, when you really trust in this new method, actually you will see there is no patient anymore who is not following you when you say, for example, let's go for a block or with vital bone. So we are cutting it then, the split bone technique of Professor Curry, I said already. So we are splitting it into thin plates. And these plates, we are scraping even more because we need the particles, remember. So we are having our plates, we are filling it with the particles. You see it here. And actually then we are building this container. And this container is filled then with the chips. Okay, that's very important. You see here the particles, and imagine also how much money you can save. So let's say maybe 1 or 2 packages is $200 plus the membrane, another $50. So it's $250 for one intervention. And now imagine you do this maybe on a daily basis. So in fact, it's also a lot of money we are saving, and I say always, we are saving millions, because we are doing this now more than 11 years. And we are working only in the sinus with bone substitute. In all other indications, we don't need them. So, and the patients are very happy with it, and the results are very reliable. So we are fixing then our plates on distance. You see, we are creating a width of not more than 8 millimeters. So there is no need for over augmenting, because it's also not shrinking. There is none or almost none resorption. And this is actually filled then with the chips. You see here come the chips. Actually, it's also quite fast. So the bone harvesting takes maybe 10 minutes, then the splitting takes another 3 minutes, then the scraping takes another 5 minutes. So in less than 20 minutes, you have everything you need. Also inductive, very powerful material. And here it goes. So you condense it, okay? So you have to condense it to avoid infiltration of fibroblasts, because you don't want that. But it also won't happen if you condense it in a proper way. So I will give you, I prepared something, a special offer for you at the end of this presentation, where you learn all the secrets, all small details, because I try to put as many as possible in this webinar, but in these 45 minutes, you cannot give all. So actually, this is how it looks at the end. You see, this is real bone. We can place here now our implants in real bone. And I think this is also what you want to have for you, or for your family member or your good friend. You want to have something natural, because nowadays everybody cares what they eat. You don't want to have something in your body what you don't know, and this is really permanent in your body. So you want to have something natural, I think, in your body. And yeah, so this the first secret was you want to have vital bone around the implants. The second secret is you want to have fixed mucosa around the implants. You see it here, because when the patient is eating, speaking, laughing, there is no movement around. And one more case. Actually, time is really running. Vertical augmentation. And you remember, this was actually the case where we were starting with. So you remember, this was the vertical defect. My father placed the implants 30 years ago, and good friend of family. And actually, I was scared before with my GBR methods to go for it. It's also already 11 years old, 10 years old, was one of my first vertical cases many years ago. But when I learned this concept now with real bone, I felt ready, and it's also now still a very stable result. And what you see here now is the so-called bony lid method. That means I cut the bone block out to take the implant out. And you can do this method also in the sinus, for example, and then it's called Lindorf approach. You can also use Trefine instead. But in this particular case, I would not recommend to do it with a reverse torque, because you see there's like a small basket at the end of this implant apically. And this is the reason why reverse torque is not working so well here. You see, we can take it out, and now we just put the block back. So it's quite simple. It was actually originally invented for doing apicoectomy in the lower mandible, this bony lid method. And once more, you see here the bone harvesting. Again, later you get here all small details you need to know. 2 vertical cuts, 1 horizontal cut. So the average time is maybe 6 minutes, 6-7 minutes to take the block out. The osteotomies should be crossed, okay? And also the angle is important, that you choose the right angle for the apical or horizontal incision. And crassly, we are using no incision. We are using drills, perforations. You see it here. And yeah, by doing this, we are creating a tension. And the moment when the tension relieves, the block is almost jumping out. You see, when you do the osteotomies correctly, so the block comes out. You see it also on my Instagram account, Dr. Frank Zastrow, many videos where from the moment I'm starting hammering, it takes maybe half a second, okay? If it takes long, maybe 3 seconds, okay? So you just need the right protocol. And yeah, then you're splitting it like you have seen before. You're splitting it, you're scraping it. I think we can go through this a little bit faster. And then you have to give it the right shape, okay? Now we are doing a little bit like arts. What I'm doing now is the right angle technique. That means I'm doing one roof plate like this and another plate like this, okay? You cannot go vertically with just one plate. It's not possible, okay? Sometimes I see that people are placing it slightly higher. Don't do this. When you go lateral, you should be on the same level like the residual bone. So I just stop here maybe just for a second. You can do this only with 2 plates, either parallel technique or the right angle technique. Okay, you see here the distance, maybe 8 millimeter we created here. And now, again, the principle is always the same. Always, it's a no-brainer. So we are filling this now with the chips. Another detail, look at my finger lingually. So you see I'm pushing slightly against the lingual tissue, that the chips are not pushed into the sublingual space, okay? So, and yeah, from outside, you place another plate on the outside. Very important, because here you have high muscle activity, while in the mandible, lingually, you don't have any movement. Same like in the palate. That's why we are not placing a plate on the lingual side and also not on the palatal side. Only 2 plates are needed. One occlusally, one buccally, and you see here also the incision line. It was not doing crestally. So when we are going vertical, we are not doing a crestal incision. While when we are doing a lateral augmentation, we always can do this with the crestal incision. But again, it's all in the book, and later I will give you the chance to read it. And you see here the X-ray, the new level, and we do here also the re-entry, because you see a very flat vestibule with the Kazanjan vestibuloplasty. Later, I will also give you, for those of you who are interested in this, the possibility to learn about this technique. It's actually an alternative to free gingerbread craft. I love free gingerbread craft, but just an alternative where you can use this technique and you don't need another donor site. So you have here the bone, and this is bone. You see, when we are taking biopsy, what we do from time to time, so we have bone, the same bone. It's not mineralized yet fully, so this takes a couple of months more, but it's real bone. What you want to have, I guess, and also what you want to give also your beloved ones if they need an operation. So you see here, in this vital bone, we are placing our implants. You have actually almost none resorption. I will show you also a very, very new study from 2019 from Professor Curry, where he had a 10-year follow-up on vertical augmentation. And yeah, you see here the typical scar tissue afterwards. This is after the Cassandra vestibuloplasty. This is CAD/CAM milled, yeah, screw retained. We do all screw retained. So you all know the studies from also Thomas Linkevicius, who has done many research about this topic, that cement retained might bring the problem with actually perimplantitis because of the cement remnants. Yeah. And yeah, once more, you see here the concept, how we do the right angle technique. One blade occlusally, okay. Not too much lingually, be careful, because then the soft tissue becomes thinner. And you fill the space, then you close it with a buccal bond blade. You have to remove the sharp edges, you see here, because you don't want to cause the risk of exposure. And now you have a nice support, okay? Again, you cannot go vertically with just one blade. You need at least two, like this. The parallel technique or the right angle technique like this. And I told you about the 10-year follow-up study from 2019. You see here, 154 grafted sites. Mean vertical gain dimension, almost 8 millimeters, horizontal gain dimension, more than 8 millimeters. After you see it here in yellow, 0.63 millimeter after 10 years. So similar to, let's say, almost normal bone, we are talking about vertical augmentation. So very stable, and lateral is even much more stable. So it's not, melting like snow in the sun. We're coming to a conclusion. Choosing wisely between use of bone substitute and autogenous bone for predictable results. Outside the contour, we recommend you to work with osteoinductive bone, because osteoconductive bone only materials we have the problem. There is no impulse or no signal that says to the bone, grow out of the envelope. That's my humble opinion. We think that osteoinductive materials are much better. And when you go vertical, like you have seen at the end, so we recommend a similar tunnel approach and no crestal incision. And I guess some of you are feeling like this now. Especially for those of you who are having actually or heard this method first time. So may I ask you a question? I told you already, I prepared something. So if you allow me the next 5 to 10 minutes, I would give you this special offer for those of you who want to implement those techniques in your daily practice. And afterwards, we are going into the Q&A session. So, like some of you might know already that, I do my courses. It's actually 2-day courses, VIP courses now because of the pandemic situation. It's first time that we recorded that we recorded the content of our Real Bone Builders VIP course. Usually our VIP course, the 2-day course here, costs 3,190 euro. And the online content has actually a value of 890 euro. But don't worry, we made especially for this, for GIS, a special offer at the end. And what is inside? So we have actually 6 modules, a 6 module VIP online course. So where we are talking about all the step-by-step explanations, how to get to a very reliable result. We're talking about module 2, safe bone harvesting from the external oblique step by step, then vestibuloplasty, then complication treatment, maybe the most important chapter, module 5, rehabilitation of the atrophied maxilla. So actually this is our money machine. So we are charging 30,000 euro for one jaw, and we can get here to a very reliable result. And yeah, for the real experts, the aesthetic zone, how to handle it, module 6. So a lot of content, all condensed like the particles actually. And still, some of you might think now, okay, this is working in your hands, but not in mine. But I can really tell you one thing. It's working in everybody's hands. Yeah, who is willing to go for it. Really trust me in this, because just go to our Instagram account, Dr. Frank Zastrow, you will see 80% of the cases I'm reposting there are not my cases anymore, but from former students, from colleagues who have wonderful results, who are working 100% in their clinic only with this concept.
I would say that if you're serious about bone building and want something far more predictable and safe for your patients, this is the course to come to. Auf Wiedersehen.
So my good friend Adnan Rehman, who also joined the course recently, he's having wonderful results also. And I said already, please go on our Instagram. Meanwhile, it's really also exploding. We hit the 18,000 soon. And all the cases you see there, most of them are actually cases from really, really very good surgeons who joined the course, who are going for this concept now on a daily basis. So, and yeah, just check it out. Don't, I said it in the beginning, maybe you remember, don't believe me, just trust your eyes, trust your gut feeling, what makes sense from a biological understanding, okay? And then make your own experience and follow us maybe. So besides, additionally to this content, we also want to give you the recordings of our live operations. So you see really everything. So we are not hiding anything. You see step by step how I'm holding my instrument and so on. So which has a value of 690.
Or live operation, so the participants can see this via live stream here from the classroom, even ask questions.
So actually, these are my learnings from the last decade, and we were thinking how we can give it like an all-inclusive solution. And what we made is the so-called VIP membership. So it's a lot of included, also the live operation and some more benefits. It's all inclusive, and let's just have a quick look on it.
So welcome. So finally we made it on our My Implant business platform. You will see all you need to become a real bone builder. Our courses, our online shop, but very new, our VIP membership. So let's have a look on it. So you will get live operation recordings, a lot of more benefits. And when we have a look now to one of our 6 modules, you see here the safe bone harvesting protocol. And while I'm hammering, the assistant is holding the chin. This is quite important. And on the other side, the patient has a biting device. In those cases, when the block is not coming out in that moment when you're at the chisel, in 90% it's because you don't have this overlapping of the incision. So this is quite important. And the second mistake that can be done could also be the wrong angle of the perforation, but I will show you also on the whiteboard. Okay, 1 to 2 millimeter, usually nothing can happen, and still you are able to take out the block. And here in this area, again, you're safe again. Okay, so this is the protocol for safe bone harvesting from the external oblique. And of course, here you do the perforations.
So actually, these are all the learnings. It's all packed in this course, and the VIP membership contains also bonuses and benefits on our former courses, on our symposium, which we will have. And one more thing.
What these guys are doing is very remarkable. They seem to have fully cracked the code on significant bony reconstruction.
I'm not really satisfied with the GBR results, and that's why I wanted to try something new, to get to know, to broaden my knowledge with bone blocks, and to gain the knowledge how to achieve very predictable results.
So actually the code, what I give you is the ebook, Safe Bone Harvesting. And together we have a value now from €2,339. Let's have a look to the ebook.
Including in this membership, you see also our Safe Bone Harvesting ebook. You see here all the tips and tricks you need to fulfill these methods. So pages and pages full of all these little tips and tricks. You need how to take blocks, how to overcome all the challenges, what is important to know when it comes to the nerve, and so on, to have a 100% safe bone harvesting. So overall, go now to My Implant Business, go on the VIP membership, become a VIP member, and hope to see you there soon. Bye, Frank.
So, of course, I won't charge you now 2,339 euro, but if you would now save so much money, and if you would get also these predictable results like I promised you, would it be worth at least to you this money? And if you yourself would be empowered now to do these techniques, would it be worth at least that money? And I'm just asking you now, what value would you give to this whole package? So how much would you pay to become really a master in this concept? And
they share everything, tips and tricks and all that stuff that can make the difference.
So I suggest this course for everybody who would like to start to work with a real bone.
I will definitely try to change my methods of augmentation for his way.
I recommend this course for any oral surgeon who would like to make upgrade for his level of surgery.
I think overall was something fantastic. I would highly recommend this to everyone to come to this training.
So really great, also meanwhile friends and former participants from the course. And actually this is the price. We were really shrinking it, and I think it gives a lot of added value. And of course it's up to you now. You can either say, okay, I don't need it, but probably then you a little bit wasted the last 1 hour, because probably it will be hard to implement all these things in your daily base without having these all these informations behind. Or you take just the leap of faith now. So you take the step and give it a try. So then go on bba-academy.com/GIS. Okay, this is a special offer only for this webinar now with Keanu Shah and GIS. And especially for this, we also want to give you another benefit or a discount code. So when you put in BBA-VIP-10, you will get another 10% off. And it will be now until midnight. And still, it's not only about the value we want to give you, but it's really about also the money you can save. And it's really not just a few thousand euro. But when we are just calculating, I said already before, just 1 month, let's say maybe 2 bottles from any bone substitutes, maybe $200, maybe another membrane, 250, and you do this maybe just two times per week. And I know many of you are doing this every day. And this would be 8 operations. That means $2,000 just in 1 month. That means in 1 year we are talking about 24,000 euro, and that means in 10 years actually we are talking about $250,000. And I know many of you are doing a lot of more. So I saved actually also millions by going for this concept. And especially after this crisis now, we have to work very economically. So give it maybe a try and check it out. And you also have never to have fear again before the re-entry, sometimes with weaker materials. At least I didn't know what I will find. And here, you know, it will be reborn, and we have to wait only 3 to 4 months. So we're very fast with this method. Very reliable. That means you can position yourself as a well-known expert in the field of dental implantology and rise your reputation among other doctors, because you will be the one who can handle those difficult situations in a very predictable way. And by doing this, so we are changing now the screen. Just have a look. Go to BBA-Academy, BBA for Biological Bone Augmentation, academy.com/GIS. Put in your special discount code BBA-VIP-10, get the 10%, and that's really worth the money. And Raquel, do we have some questions meanwhile?
Yeah, we have a lot of interesting questions. So I will start with the first question that was from Dr. Weston Sands, that is asking, do you ever utilize PRF during bone augmentation procedures?
So honestly, we have PRF just a half a year now in our clinic, and we don't have too much experience with it yet. I believe that so we have already the growth factors actually in our material we are working with. So we are having actually all the growth factors in the autogenous bone. So, but still, there might be a difference. I don't know yet. So we have to do some split mouth studies, and then we will see. Where I see definitely a benefit is in patients with a suppressed immune system, for example, smokers or also others, because there's a high amount of leukocytes also inside. So when we have this group of patients, I think definitely this has a benefit to the result.
And I think also PRF can also help a lot in the soft tissue healing, being more quickly. But as you told, you already have all the stem cells, all the gold standard there. So if you have a good soft tissue, maybe you don't need the PRF. If you have like very thin soft tissue, it can be something that can bring some healing and some...
we will do some research, yes.
Yeah, and stimulate the healing. Another question from Dr. Long Hero. Do you use collagen membrane when you do this kind of procedures or not?
Very, very good question. We were a little bit short in time. That's why I could not go on every step too much, but probably you didn't see a membrane. So we are also not using membrane because the BBA concept or biological bone augmentation is totally different from GBR. Also, I had to change my mind completely. So what is the point? So when we are working with bone substitutes, osteoconductive bone substitutes, it's like a scaffold, okay? So that means if you would not use a membrane, so what would happen? The fastest growing tissue would infiltrate fibroblasts, so immediately, because bone is more slowly. And this is why we have to place a membrane. But when we are working with autogenous bone particles, where we have also vital bone cells inside, we don't have to cover it with membrane because it will not be infiltrated from fibroblasts. Some of you might think now, okay, maybe it's not needed, but I'm dentist and I have too much money, so anyway, I will put a membrane. But the problem is now, why is this concept working so nice? And you see all the cases also, not in my hands, from so many colleagues now on my Instagram account, for example. Why is it working so good? Because we are not working with a full cortical block. We are particulating it. We are creating more access because we have a large surface for the blood vessels. Okay. What happens if we would place a membrane over it? We would cut the blood supply, and we need the blood. We need also the blood vessels from the soft tissue. So please, when you're working with this method, don't mix it. So don't take the different receipts together. It's like when you're baking your cake. So you have to stay with the recipe. Don't mix it too much because it tastes good or it's falling together. So no membrane.
Yeah, I agree, because your membrane is the bone plate, basically, is doing the isolation of the...
It brings the stability. It's not really, it has not the idea of a membrane, but the stability, exactly, yeah.
And we need the irrigation to have the healing. So, of course, it's more logical not to put. I think to be logical, eventually the PRF can be logical because it will stimulate the new vessels. But not a collagen.
Maybe to mix it with IPRF. So I'm really looking forward to do here some research. Yes.
That would be nice. Another question for Dr. Shabat Farahari, I think. Please explain about the exact anatomical landmarks for bone block in retromolar area.
So it would take probably a little bit too long time. It's also on the inside, it's 40 pages actually. So, but what is the main part is when we are taking a block, what we should never do is we should never go into the ramus. Many are calling it the ramus graft, which is actually not correct, because we should stay away from the ramus, because here, so the nerve is more, so you look here, the ramus here, it's very thin, okay? Here it's very thin. That means we don't want to go to the ramus because there is the nerve more on the surface from both sides, because where else should it be? Where we want to take the block from is from the retromolar area, okay? You see here, it's like a balcony. It's really convex structure. That also makes it so easy to collect bone from there. For example, compare with the chin. Some people are going for the chin. This is an inside the contour structure. It's much harder to take it from the chin than taking this nice balcony or belly from here. So this is maybe the most important when you're talking about anatomical structures. Stay away from the ramus. Stay in this area, okay? Don't go here into the ramus.
Yeah, and basically use the external obliqual line as a guidance, basically, because you have
absolutely. Yeah. You're harvesting the external oblique line, not anything else. Mm-hmm.
Yeah, yeah. You already answered the question of Dr. Aishwarya Kadu. Which graft do you prefer, shin graft or ramus graft? What gives you better result? You already answered. So basically, I can continue because
99% we are going for retromolar because it's much easier, much faster.
And in terms of bone quality, I think it's even better because the chin normally is very cortical in the middle line, in the symphysis.
You can also collect a lot of spongious bone from the chin, because when we are taking a block from here, we can even go to the lingual border, so we can collect all the spongious bone, what we cannot do in the retromolar area. So I would say it's comparable, but I like the easy way.
Yeah. And the same Dr. Aishwarya Kadu is asking, do you prefer cortical cancellous or cortical graft?
Absolutely not. So we are going for cortical bone only. So because this makes also the harvesting easier. So we are actually trying to get only the cortical plate. So also the angle from our perforations is that way, that we are not going too much lingually, because this is much more invasive. We have to hammer a lot of more. We take a risk to the nerve, everything. So we want only to have the cortical bone plate, the outer one. And if maybe some spongious bone is attached, that's fine. We can also use it, but this is not we are not aiming for it.
Yeah. And you can use the safe scraper for collecting these cancellous that comes within the cortical, or to thin the cortical, as you showed. Or to split the cortical in two.
Absolutely. I think you're also in love with the safe scraper, right, Raquel?
Yeah, yeah.
Scraper. So I love this instrument. And many of those who are watching now probably also love it. I can tell you one thing. If you love it now, you will love it even more when you're scraping a block with it. Why? Inside the mouth, the whole jaw and the whole head of the patient is moving, okay? Outside, you're doing this on a glass plate, okay? And you're holding it with a ronger, and then you're scraping it so it's totally rigid. Okay, that means the amount of particles you can collect is huge. So you won't have the problem, because this also sometimes a question, can we mix it with bone substitutes? My actual answer is usually, so don't get me wrong, if I say that, so either your block was too small or you were too lazy to scrape. And so it never happens that you have not enough particles. The problem is usually that you have too much particles.
Yeah, because that was also one of the questions. If you mix with some substitute, I know you don't, but
absolutely
you already answered.
No,
but
no.
by the same doctor, we have that question.
And you can learn how to take good blocks, okay? Then you don't need it.
Another question for Dr. Viniti Goel. What suturing technique was practiced to have a tension-free closure?
Okay, so very good question. So while in GBR, at least when those times, it was maybe one day when I went to a training, was about how to open it, how to close it, what materials, what techniques. While when we are talking about lateral augmentation now, I can say you the opening and the closure in one sentence. So we are always doing crestal incision, simple. One relieving incision, one vertical relieving incision, and a deep dissection of the periosteum, always, because at the end we want to have a tension-free closure. And then we are just suturing with single sutures. Simple. Why is it so simple? Because we have a superior connection between the periosteum on the bone. It's like a hemidesmosomal attachment. So, and it should work, because if not, all of us had a problem. Imagine, we are all done from bone and periosteum. So we had really big problem. So the sutures actually in GBR are for pulling it together, because we are working with foreign material, foreign body, and the patient, the body wants to get rid of foreign material. That's normal. While our connection is totally natural. That means we have a superior attachment, and the sutures are only for giving the flap the right position. The attachment itself is done by this, it's again evolution. So it took millions of years to have this wonderful connection.
Yeah, I agree. I think.
Sorry, one sentence. When we are going vertical, then we are not doing crest transition. Then we are doing tunnel technique or modified tunnel technique. So, but this would probably be a little bit too much to go here into detail.
Yeah, but I agree. I think it's more important the release of the flap than the suture technique, because if it is properly and you have bone in contact with periosteum, you have a natural connection, as you said. So you don't need to do like some special. Sometimes you do some mattress, apical mattress, in places that the tissue is very non-keratinized. So like the posterior mandible sometimes, but many times you only need like simple stitches. I agree.
Easy.
Another question for Dr. Rodney Dimoska. How do you disinfect the area after explantation of the bone? Do you use any laser type? Do you use PRF membrane, or often other materials in combination with artificial bone?
Actually, I do nothing. I just remove it and then I close. And but I don't do the bone augmentation the same time. So if I have something contaminated, for example, like an implant, for example, I remove it. So we never do the bone augmentation the same time. So we are waiting 6 to 8 weeks, and usually then, if there are maybe some inflammatory cells, usually they get deleted from the immune system from the body. So, but of course, there are also other ways. I know you're also working with. We also have it in our clinic, like laser. If you want, you can do this.
Yeah. If you play the low-level laser therapy, that can be biostimulation.
Photodynamic therapy, like Helpo, from Bremen.
Yeah, low-level laser therapy. I think it could be. It's not mandatory, but could be interesting if you have a contaminated area. Or you're doing like a big procedure of augmentation. I think it could be useful. It's not mandatory. So, I think we have a last question. Dr. Amit Wadawan, can we bend the blocks?
So maybe, so if you look very, very carefully, in one of the first cases, in the frontal area, I showed a case where we used Howie Gluckman recently called it the bending technique. So though we are using this already a long time, but there was no name for it, but he called it bending. I think it's a wonderful name. So you cannot bend it in that way like you might think, because it's cortical bone. So it's also not that you can do like a Greenwood fracture, because it's cortical bone. So it's challenging. You can do it. You can do a fracture. But it's tricky. So it's not something where you're starting with. So you have to be advanced, and in worst case you have 2 pieces.
Maybe you can try.
You have 2 pieces still, but this is also no problem. You just need the 2 more screws.
But
so,
for instance, by the way, this is my question. The screws that you are using, I see that the osteosynthesis screws have like round heads. And what type of screws are you using?
So what screws I'm using, I show you. I'm using those.
And what is the diameter?
Actually, they are very new and not on the market yet. So it's a new system which comes this year on the market. So maybe you can read it, only for real bone builders. It's written there. So I will keep you updated as soon as they are available.
You have to give me one for me to try, because
I sent you as a gift. So look forward.
I saw it in the first lecture, and today I was also paying attention, because I think the material is also very important to succeed in the technique.
Yeah, we are using titanium.
Yeah.
1 millimeter
and
diameter.
the type of screws, if they are round in the tip, the type
Absolutely.
of diameter. So it's very important not only to know the technique, but to use the right assets, the right materials to have a
Absolutely.
successful technique.
You
So
said
you have
exactly.
to give me the secret, okay?
So you said already absolutely right. So first of all, when you're choosing a system, it's very important that the threads are very narrow, because you have to get primary stability also in a thin bone plate. So you cannot use some systems because they are made for full cortical blocks. Okay, the threads are too much distance. Okay, then they don't get the primary stability. That's one thing. The second thing is, of course, it should be not too big. And the third thing is, it should have a round head, because sometimes you're going, you're coming from here, because this is the mouth of the patient. Yeah, you're coming that way, okay? Not always in a right angle, okay? Sometimes that way. And that means if you have a flat head, that means this flat head would stand out and could cause an exposure again. So if you have a round head, it doesn't matter in which angle you're placing it, it's all nicely smooth and rounded.
I think, let me check. Dr. Mohamed Rafat, the last question. What's your opinion about Ethos? Can it be used directly on implant? Do you know the brand Ethos by...
I know the bone substitutes. I didn't work with it. That's why I cannot talk too much. I think I would use it for sinus. But yeah, you know my concept. So at the crest, I'm 100%. I'm hardcore autologous. Yes.
So I think I managed to do all the questions, and I managed to do also one question for me, and I found some secret. So thank you so much, Dr. Frank Zastrow, for this brilliant conference, and for teaching your tips and your tricks. And I hope to see you soon in person, because now we have this problem. Hopefully next year in your symposium in Germany. I'll be glad to be also a speaker there. And I hope you also can come back to Portugal soon, and we can see us in person. Okay, so thank you so much. We have Kianor back. And I think it was a great session.
Wait, you're
hearing you.
Muted.
You're muted.
Okay, wow. I'm juggling like all of these functions. Thank you so much for the wonderful presentation, and thank you, Dr. Gomes, for hosting it. We look forward to many more with you, Dr. Zastrow, and our organization. That's led purely by peer-to-peer friends and colleagues of ours. Thank you for coming on today. We are getting ready to go on with Dr. Philip Gordon about in-house laboratories, which should be an interesting topic. I kindly invite all of you guys to come back into the webinar room in about 29 minutes. Thank you so much.
So go to the bathroom, drink a coffee, and come back.
Gotta do it all over again. Thank you, thank you. See you guys soon.
And tomorrow,
yeah, absolutely. Also from my side, it was really a great honor to be on your prestigious platform. You did a great job. Also, Raquel, you were such a wonderful host. Thank you so much. And I'm really looking so much forward to welcome next year on our symposium in Heidelberg here. And Keanu, all the best for your wonderful organization, that you grow, that you hit the million. And enjoy now the webinar with Philip Gordon, a fantastic guy.
Hopefully we'll have you there for the celebration. That's a great mark to achieve, having been able to be in a position to bring education and knowledge to our friends and colleagues from the most distant places in the world. And you know, we can achieve anything we want, just doctors. We don't need third parties. We can achieve it ourselves amongst each other, peer to peer. Thank you very much, Dr. Zastrow. Have a nice day, Dr. Zita. Talk to you soon.
See you tomorrow.
See you tomorrow.
See you. Bye-bye.
Bye-bye. Thank you.